A lot of people are still filtering back in. So if you could settle back in and take your seats as quickly as you can, we'll get moving forward here. All right.
Brian?
Yes?
So while they're filtering in, so why no coffee? What, you mentioned that no coffee?
No, I didn't say that. Okay, so I've been barraged with a few questions about what to eat and drink during the break. Yes. So I can make a few comments. So the one question was, someone had the idea that I was opposed to carbonated water, but that's not true. Carbonated water is fine, like Pellegrino, or you can carbonate at home, so the carbonation in the water is fine. So sparkling water is fine, flat water is fine. Now, in the blogs that I've written, and probably the simplest thing is to go to them, because there are a lot of important little details here. I have a lot of suggestions about a lot of good things which are okay to drink, which includes both tea and coffee. I think, actually, as Sagar mentioned, moderation is a good attitude. I mean, there are pros and cons to coffee, but if you have a couple of cups of coffee in the morning, that's fine. And so please take a look at the blogs, and you'll see a discussion of some of the pros and cons about both what you drink and what you eat. But the other point that was made is that, hey, when you get into remission, we don't want you to be feeling miserable because you don't have your ice cream or you don't have this. I mean, these are things that you can do in moderation, and they're definitely not going to be what kills you. But if you're eating processed food and ice cream and all these different things constantly, it could become a factor. All right, so I'm very, very pleased as part of our stellar lineup today to welcome Dr. Sagar Lonial from Atlanta, the home of Coca-Cola, but also the Winship Cancer Center, where Sagar has done a fantastic job in putting together a very strong myeloma team. And I'm very pleased to welcome Sagar to talk about what treatment is recommended in the setting of preparation for stem cell transplant. So please welcome Dr. Lonial. Thanks. This little thing, it's got a little pointer right on the tip. It's kind of sensitive, but...
Okay. Got it. All right. Well, thank you all very much for the opportunity to be here and trying to follow Drs. Durie and Kyle, who are just giants in the field, is always very daunting. So if I seem a little bit out of sync, it's only because I'm trying to live up to what they've been able to do, not just in the last few moments, but over the last years in terms of helping us to communicate well with patients and to advance the science. So I was yesterday at a retirement symposium for the first person whose lab I worked in 25 years ago at Johns Hopkins. And she was a leukemia doctor, and I was originally supposed to be a leukemia doctor until about 12 or 14 years ago when the myeloma community said, don't mess with leukemia, come work with myeloma, which was very fortuitous because it was right about the time that things were starting to get better. And I really had a chance to think about that more yesterday during this symposium where I heard lecture after lecture sort of talking to us about how nothing had really changed in leukemia over the last 20 years. And I remember thinking, my slides for tomorrow are going to show how things have changed in the last 10 years in myeloma. And it was an absolutely overwhelming feeling to be able to think about standing in front of you all today and saying, in the short duration of my career, that we have done things like change the natural history of this disease. You saw this from Dr. Kyle earlier this morning, the analysis done by the Mayo Clinic showing that for the first time in decades, we've been able to actually change the survival curve for patients with myeloma. This is no small feat. There are many, many cancers that would kill to be able to show that they changed the natural history of disease. Pardon the pun. Sometimes they want to kill me. That's okay. But I think it really is a remarkable testament to the cooperation between industry, between us as academic investigators, and between patients and their families who are willing to subject themselves to the rigors of clinical trials simply to do this, to move the bar from here up to here. And so I think it's a real positive step forward. So what I want to show you is not just all patients or patients that were in Shaji's analysis. This is a series of almost 300 patients now, we're over 300, that received the 3-drug combination RVD that you heard from Dr. Kyle earlier for high-risk patients. We at Emory give it to all patients. And this is the survival curve for patients who got RVD at our center. I mean, that's 5-year survival of almost 90%. That, to me, is phenomenally good data. Phenomenally good data. And while I'd like to tell you it's all because of me, that is simply not the case. This is what I think is occurring at centers around the country that are using modern induction approaches, modern consolidation, the right timing of transplantation, and these have all led us to get from curves that were no different for 40 years to curves that are now starting to show survival curves like this, which, again, I think is really quite exciting. So what are the questions in the transplant-eligible patient population that you want to know a little bit about and that I'm going to spend the next few minutes trying to give you some information on? And these are the 4 that I came up with. 1, do I need therapy? And Dr. Kyle already hit on this a little bit. What I'm going to do is just talk a little bit about a couple of trials that I think are really important and exciting. Should I have 2 drugs, 3 drugs, or 4 in my initial treatment? Should I have a transplant? Probably the most common question I get. I think I got it 4 times during the break. And I think it's an important question because there's a lot of new data really speaking to the importance of transplantation. And then finally, should I have maintenance therapy? And this, again, is another area where there are a few data sets that help to inform us, but there are also other approaches that are sort of early on in their use that I think will help us to address some of these questions. So you saw from Dr. Kyle earlier today the difference between patients who historically we don't treat versus patients that we do treat, patients who have basically CRAB criteria. What we've noticed, however, is that there are patients in this smoldering or what is now called asymptomatic myeloma category that have a high rate of progression to myeloma. And those are patients whose average time from the diagnosis of smoldering to symptomatic is often somewhere around 2 to 3 years. And that's pretty short. When you think about MGUS, where the average time can be 50 years, right? 1% per year, so the average time is 50 years. 10% per year for smoldering on average, so that means the average time is 5 years. If you've got a group of patients that can convert in 2 years, that's an important piece of information to know. And they probably have myeloma, they just don't have these signs of end organ damage. And this is now becoming a really big area of laboratory and clinical investigation. At our center, we have 3 trials open just for patients with high-risk smoldering myeloma. And the most important one, not because I'm the leader of that one, but because it is the most important one, is a randomized trial comparing high-risk patients to get either lenalidomide, Revlimid, or observation. And I think, as Dr. Kyle mentioned earlier, observation is the standard treatment. We don't have data right now that says we should do anything other than observe a patient. And so introducing therapy like Revlimid is an important investigational question. We do also have a vaccine trial, and we have monoclonal antibody trials as well for patients who fit this high risk. Not every smoldering patient is high risk, but of that 25 to 30% that do fit high risk, those are patients we want to try and potentially intervene earlier in. So let's talk about patients who definitely need treatment. What are the goals of treatment in these patients? And as you can see, high response rate. We want to make those myeloma cells go away, and we want to do it at a very high level. We want that response to be rapid. We don't want something where patients have to take 6, 8, 10, 12 months of therapy before we really start to see a significant effect. You and I, or at least I, want instant gratification. I'm younger, perhaps. That's why I'm not part of this millennium generation, but I like to see quick responses, and I think patients like to see quick responses, so that's something we're looking for. We want to improve a patient's performance status, and performance status is a medical term for how well you are. That's really what it is. And part of the goal of induction therapy is taking a patient with symptomatic myeloma and making them less symptomatic. So the goal of induction should not be to give you horrendous side effects. That's not the goal. The goal is to do these things, but at the same time, make you better. And finally, the goal should be, for younger patients, which is what we're talking about, we should not limit the ability to collect stem cells. And I know many centers like ours now are starting to collect enough for 2 or 3 or multiple transplants down the road. That doesn't mean that we're going to do them all at once. It just means we want to have insurance policies in the bank. And I think one of the things, we're going to talk about transplant later on, but one of the areas that we're finding is that patients that have been on treatment for 8, 9, 10 years, oftentimes their blood counts really start to drop. And you can't do anything because their blood counts are so low. The white count is low, the platelets are low, and in those situations, having reserved stem cells in the freezer can actually help to what I call repopulate the bone marrow. And it means you're not doing it because you want to put them back in remission. You're doing it because you want to give blood counts again. And that allows you to deliver more treatment. So it's sort of it's like cheating, I guess, in many ways. So let's talk a little bit about 2 drug combinations. This is lenalidomide and dex, or Revlimid and dexamethasone, and this was the trial from ECOG, and Mike Katz is somewhere in the room. Where's Mike? Where's Mike? There he is. Mike's in the way back. Mike is the one that helped us design, actually it was his idea to do the high-dose dexamethasone versus the low-dose dexamethasone. And what I think you can see, again, is a very high overall response rate. But one of the things that I want to point out when I talk about the importance of 3-drug therapy, the reason I showed you that survival curve in the very beginning is that 3-drug therapy to me represents a way to get very high response rates. And while 68% is great, that means that roughly 30% of patients at the time of diagnosis don't achieve a partial response. And that's a third of patients. We can do better than that by putting drugs together. And so that's one of the messages that I want us to take home. What about looking at the other doublet, bortezomib and dex, versus old school therapy? This is basically high-dose dexamethasone alone again. And again, if you look at what you get after induction therapy and start to add some of these numbers up, you can see that roughly 25 to 30% of patients don't achieve a partial response after their initial therapy. So it's great for 2/3 of patients, but that 1/3, just like with Len-Dex, don't achieve a partial response or better. Why do we want to leave 1/3 of patients out? I want everybody to be included, right? Everybody, just like all of you guys should be able to get on a plane and come to Atlanta to see us at Emory. I want everybody to be able to have a major response after their initial induction therapy. So what is the advantages of combinations? Well, you get a higher response rate. And we know that higher response rate early on correlates with better long-term outcomes. So you heard this from Dr. Durie earlier. You heard it from Dr. Kyle as well. How do you maximize responses? By using combinations of drugs. We also know that by using combinations, you attack a cancer cell from multiple different sides, which helps you to knock them out. Myeloma cells are not stupid. I wish they were stupid. It would make my job a lot easier. These are smart cells, and when you hit them with one drug, they find a way to get around that drug and do something else. So if you really want to try and eliminate cells, you need to hit it from multiple sides at one time, just like we do in other cancers where we actually are able to cure diseases like Hodgkin's disease, non-Hodgkin's lymphoma. Many diseases, we use combinations of drugs to really try and knock it out. And you get what we call synergy when you use these drugs together that you don't get when you give them by themselves. So this, to me, is the real representative of why to use combination therapy. This is an Italian trial that looked at 3 drugs, Velcade, thalidomide, and dex, versus thalidomide and dexamethasone. And the real reason I want to show this to you is, look, 61% of patients achieved not a PR, a VGPR. The response rate was almost 97, 96% in this trial. That's almost everybody had at least a partial response, and 2/3 of patients had a very good partial response overall. This is the power of combination therapy. And so in my mind, 3 drugs does represent a significant step forward over the doublets of either Len-Dex or bortezomib-dex. Now, we know that the problem with thalidomide and bortezomib is overlapping neuropathy. So what if you substitute out thalidomide with lenalidomide or Revlimid? Then you get RVD, which is what I showed you earlier on. And this was the response rate. Everybody responded. I always show this in grand rounds meetings with the solid tumor oncologists just to make them jealous. This is a disease where everybody can have a response to their initial treatment. And as you can see, 100% is pretty good. It's hard to beat that. And the way we get better is we start to increase the CR, the complete remission, and the VGPR rate. But this, to me, does represent in many ways a standard for how patients who are young and fit, newly diagnosed, should be treated before they undergo stem cell collection. And the other reason I think it's important is that using combinations of a proteasome inhibitor and an IMiD, Velcade and Revlimid, allows us to narrow the gap between high-risk and standard-risk genetics. This is the survival curve that I showed you in that previous series of, now it's over, like I said, it's over 300 patients now. Normally these curves are really different. They're really different because old therapies don't work for high-risk myeloma. But look, these curves are statistically the same. Why is that? Aggressive induction, aggressive and appropriate use of transplantation, and then aggressive maintenance on the back end helps us to overcome some of the negative side effects associated with high-risk genetics. So that's the real power of combination therapy. And it's a regimen, RVD as we talked about before, that is chemo-free. There's no chemotherapy in RVD. It's Velcade, Revlimid, dexamethasone. I consider those to be non-chemotherapy-based approaches to treat myeloma. And I know patients hate chemotherapy, so that's a good way to think about it. What about incorporating some of our newer drugs? So this is a data set from our colleagues at the NIH looking at replacing the bortezomib or the Velcade with carfilzomib, the newer proteasome inhibitor. And so this is carfilzomib up front, and as you can see, again, very, very high response rate when you use carfilzomib with Revlimid and dexamethasone, and the responses are quite rapid as well. If you look at patients in yellow and green, you can see here the fraction of NCRs goes up markedly with just 2, 4, 6, or 8 cycles of treatment. Very, very rapid responses. And as we took out thalidomide to try and reduce the overlapping neuropathy when you combine bortezomib and thalidomide, the neuropathy associated with carfilzomib appears to be less than what we see with the RVD regimen. And so again, this represents a refinement of what I think is a great regimen, a proteasome inhibitor and an IMiD in combination for newly diagnosed myeloma. Now, not to be outdone, we've talked about IV versions. What about a completely oral regimen? Only a bag of pills. You come into the doctor, we give you a bag of pills, you go home, you see us back in a month, right? That wouldn't be so bad. And this is using the oral proteasome inhibitor MLN9708, or the new name is Ixazomib, I-X-A-M-O-M-I-B. I'm sure I've missed some letters there, but Ixazomib is the new name for this. And so in I put my marketing hat on and think about how can we get a catchy name for Ixazomib, lenalidomide, and dexamethasone. I call it RID. Get rid of myeloma, right? I knew you guys would like that. And again, as you can see, with only pills, 3 drugs, oral proteasome inhibitor, Revlimid, and dexamethasone, almost 90% of patients respond, and almost 2/3 have a very good partial response or better. This is patients coming in. Right now, they have to come in more frequently because we're early on in the trial. But the goal here would be that patients really come in once a month and see us with a completely oral 3-drug combination that takes the most active drugs, proteasome inhibitors and immunomodulatory agents, and puts them together to really get a major response. Now, I like more. I'm a combination kind of guy. And so what we presented at ASH was this year with some data with a 4-drug combination. And I can tell you that 4 drugs are coming. There will be 4-drug combinations, but they will probably not include chemotherapy. Because what we've learned from a number of trials is that adding in Cytoxan or cyclophosphamide, adding in doxorubicin, which is another chemotherapy drug like Doxil, it doesn't help. It really just adds side effects. It doesn't make things better. So when we think about adding that 4th drug in, we got to be smart. We can't go back to old school chemotherapy. I think we need to think about newer drugs like monoclonal antibodies or like HDAC inhibitors, as Dr. Kyle mentioned. And this is where we may really start to think about individualizing what that 4th drug is based on the genomic and the genetic makeup of a given patient. And that's what I think is really important. In my mind, the triplet of a proteasome inhibitor, and an IMiD and DEX is good for almost everybody. The question is, what do you add to that to get even better responses based on a patient's individual genetics? And that I think is an important question. So, in my mind, 3 drugs do represent the standard for most patients. These combinations can include chemo. There's a big movement that uses Cytoxan in combination with bortezomib, the so-called Cybor-D regimen. That, I can't tell you, is not as good as the RVD. I prefer to avoid chemotherapy in patients for a number of reasons, but either you can do a 3-drug combination with cyclophosphamide or the IMiD proteasome inhibitor combinations, the RVD regimen I showed you earlier, CRD with carfilzomib, or RID, get rid of myeloma, right? Combinations result in higher overall response rate, higher depth of response, and better post-transplant outcomes. And what we're trying to understand is, does it improve survival? And I think that's really an important question. One can argue that my data that I showed you earlier on is people who were fit and well and could come to see me at Emory. And that's a fair criticism. What I can tell you is we have a whole lot of high-risk patients. So even the numbers I'm showing you include roughly 20 to 25% of patients who are high risk. So we're taking everybody into the pot. But it's possible that we see a selected patient population, and we need studies that show survival to really ultimately answer the question. So, transplant, yes or no, age limitations, and timing. These are really the 3 questions that come up most frequently, and I'm going to answer the first one easily, and the answer is yes. You should have stem cells collected early on in the course of your disease. Doesn't mean you have to use them immediately, but you should have stem cells collected because high-dose therapy and transplant is an important treatment for many, many patients. And there's no reason to lose that opportunity at having another treatment option that you may use at some point down the road. In my mind, I think about all these new drugs and all these new treatment approaches as doors. And as you progress down the course of treatment, you walk down a hall and you start to close doors. I don't want any doors to be closed. I want you to have as many doors open as you need so that if you need a certain treatment, you've got it. That's sort of how I think about it. What about age limitations? I'm going to show you some data on this. We don't think there is a significant age limitation, although above 78, it probably does start to become a little bit of risk-benefit ratio where it's not quite as clear. And timing, we're going to talk a little bit about that as well. So why do I say transplant is important? Well, these are the 2 large randomized trials, the first trials to improve survival in patients with myeloma. This was from the French, and not to be outdone, this version is from the British. You know, they still continue to feud amongst themselves. And so, as you can see here, the IFM showed an improvement in survival, as did the MRC, which was the British trial. So I think it's important to keep that in mind, that transplant does offer benefit. Now, what about age? I hear all the time, I'm too old, my doctor says I'm too old, I can't have a transplant. This is an analysis done at our center for patients who were greater than age 65 who had high-dose therapy and autologous transplant. So what you can see on green is their survival curve. And again, this is relatively older data in the sense that we go back almost 8 to 9 years. So this was before we had things like RVD for newly diagnosed myeloma patients. But as you can see, this is the survival of patients at our place who had a transplant over age 65. This is the survival of patients in the SEER database who are over the age of 65. Now, does this mean that everybody should not go to SEER and they should all come to me? No, I'm not saying that, although that's not a bad idea. What I am saying is that in the right patients, they can have significant benefit from high-dose therapy and transplant independent of age. And I think most transplant centers follow that rule. This, to me, is justification to say if you pick your patients correctly, you can have good outcomes when you're over the age of 65 with high-dose therapy and autologous transplant. So age should not be an independent limitation. What about early versus late? Well, to me, there's one trial from France that says early versus late, the survival is the same. What about modern data with modern trials? Well, this is a trial from Antonio Palumbo where everybody got lenalidomide and dex early on, and then they were randomized to either a transplant or consolidation with low-dose melphalan, so the MPR regimen that you heard from Dr. Kyle earlier. So melphalan, prednisone, and lenalidomide. And I'll tell you the hard part about this randomization here is that I'm not sure this arm really got the fair shake because they got less Revlimid because they had to, by adding in oral melphalan to it. There was then a second maintenance then there was a second randomization to either maintenance with Revlimid or no maintenance. And what you can see here is that the duration of remission, that's what PFS, progression-free survival, how long that first remission lasted was much longer in the group that had a transplant than the group that did not have a transplant. And that, to me, is really important. And the reason I say it's important is that first remission with available drugs is probably one of the longer remissions a patient will experience. The disease is at its most sensitive early on. And that, to me, again, is a reason to use combination therapy early because you get the maximum mileage out of the effective drugs, and that's a reason to try and maximize how long you stay in remission, because this first remission duration, in my mind, is really very important. Now, we may get new drugs that change that paradigm, but with drugs that we have right now, one of our goals is to maximize the duration of that first response. So what about looking at our center? I've showed you a lot of data from our center. These are patients who either had an early transplant, meaning we said that they should go on to a transplant immediately, or they collected cells and went on to a delayed transplant. And what I want to tell you is not that everybody should have a delayed transplant so they can fit on this top curve, right? Because everybody wants to be on the top curve. What I want you to realize is that these patients are very well selected. We have cherry-picked the best patients to go into the delayed transplant group. Anybody with high-risk disease didn't go into the delayed transplant group. They went down here into the early group. So with appropriate patient selection, you can do just as well with a delayed transplant as you do with an early transplant. But it doesn't mean that everybody can just flip a coin and say, well, I'm going to delay it or I'm going to do it, unless you're in the context of a clinical trial. And there is a trial that's asking that very question. If you have a choice, you need to think, do I fit the criteria that allows me to think about a delayed transplant, or should I go forward and go ahead and do it now? And again, that's in the absence of a clinical trial. So what are the trials that are trying to answer this question once and for all? Well, this is the IFM Dana-Farber trial, which is over 1,000 patients with newly diagnosed myeloma, where every patient gets RVD as their initial treatment, everybody gets stem cells collected, and then there's a randomization to either transplant or more RVD. And this, to me, looks like a more fair comparison because you don't have limitations of drug dosing because you're trying to squeeze in some oral melphalan there. This is full-dose RVD, similar to what they got here. This, to me, is a really important comparison. And this trial is being stratified by genetics. So we're going to learn whether standard risk genetics, high risk genetics, whether it matters when they have their transplant, which I think is a really important question. Like I said, it's one of the most common questions I get asked at meetings when my patients come to see me. Should I do it early? Should I do it late? I tell them what I think we should do, but I don't know that. And this is really what's going to help us to answer that question. So, what about maintenance? Well, before we get to maintenance, transplant has a role, and the timing of transplant is being explored in trials. And so what I'll tell you is there's no easy answer for that, but it is something to think about and talk very carefully with your doctor about. How can I maximize the duration of that first response? Is early or delayed transplant the right thing for me? What about maintenance therapy? Well, I think maintenance therapy is actually really important. And there are a couple of trials that talked about that. The first is the Dutch trial that gave everybody what I consider somewhat old-school therapy, VAD, vincristine, adriamycin, and dexamethasone, and the other group got PAD. So in Arm A, you got old-school therapy, VAD, CAD, not so bad. They then had a transplant, and they got thalidomide maintenance. That's the one arm. The other arm got PAD, CAD, they got a transplant, and then they got Velcade maintenance. So basically, it's old therapy versus new therapy. That's sort of how I think about it. And these are really complicated, but what I want you to notice is that Arm B is the arm that got Velcade maintenance. And as you can see, whether you had deletion 13, 414, or 17p, the group that got Velcade maintenance in brown here did better across the board in terms of progression-free and overall survival. So Velcade can be an important maintenance approach if it's done in a way that we think is appropriate. What about lenalidomide? This was the U.S. trial. Finally, there's a large randomized phase 3 trial that we did in the United States. We're not having to depend on our European colleagues for all the data. These were patients that had a transplant and then got randomized to lenalidomide or Revlimid versus placebo. And what you see here is Revlimid doubles how long you stay in remission compared to placebo, and Revlimid improves your survival. You live longer if you got Revlimid maintenance than if you didn't. Now, the French did a similar trial where they did not show a difference in overall survival. They showed an identical difference in terms of how long you stayed in remission, but did not show a difference in survival. And there are lots of reasons why the two trials may have had slightly different results. In my mind, I think this trial does represent certainly why I support the use of Revlimid maintenance, but it's an individualized discussion. And the reason it's individualized is because of this. Using Revlimid did not come without a price, and that price was the risk of second primary malignancy. So that's a new cancer unrelated to myeloma. And as you can see here, in the group that got Revlimid, there were a few other cancers, AML, MDS, ALL, Hodgkin's. There were a couple of other cancers like esophageal, colon, breast, lung, that may or may not have been related to the Revlimid. It's hard to say they weren't in any way related because this is the group that got placebo, and that number is still clearly lower. So when we talk about risk-benefit, I showed you the benefit, improved overall survival. This is the risk, higher risk of potentially a second malignancy. So 4.2% versus 1.7%. So if you're an extremist, you'll say, that's 2.5 times higher. If you're not an extremist, if you're somebody who just looks at the data, 4.2% is higher, but it's about the level that I quote most of my patients for post-transplant MDS, which is about 5 to 7% at 10 years. And in fact, if you look at competing risks, this is the risk of having bad outcomes. The highest risk was on the placebo arm in terms of disease progression. If you look at second primary malignancy down here, it's much lower than either relapse or death for another reason. So in my mind, in the competing risk model, I'd rather keep the disease in remission longer and maintain that and take a little bit higher risk than worry about relapse or death from another cause. So again, and the way I think about it is the risk-benefit ratio does favor Revlimid in this situation, but it's an individual patient-based decision as we think about it. So we've talked a lot, you heard from Dr. Kyle earlier on, the idea that we want to try and get patients to complete remission. And I think that has been our goal for a long, long period of time. And the reason is we think that complete remission correlates with better outcomes. But the reality is that with our current definition of complete remission, we're still down to about here on the iceberg of myeloma. And our goal is not to be down here. Our goal is to be down here, to make that iceberg go away. So your boat can sail safely through the waters, right? That's what we want. This is down on the beach, so I got to put the boat metaphor in here. So as you think about it, what is the role of maintenance and consolidation? It's not just to get you to a complete remission. It's actually to get you down to what we call molecular or flow cytometric remission, or even ultimately to a cure. That would be certainly an important goal, right? And so maintenance may be a way to get there. So in my mind, there is a role for maintenance in many patients. Maintenance, in my mind, should also be risk-adapted, meaning your genetics should help guide your maintenance. If you have high-risk myeloma, then one drug is probably not enough. You need more than one drug. If you have standard risk myeloma, then one drug may be enough, and we try and understand which drug might be the one to do that. But again, ultimately, risks and benefits have to be discussed, and as a patient and doctor, you have to decide, yep, I know this is the risk, but this is what I think is the benefit, and I'm willing to go down that road. So how do you define cure, right? I'm not Bart Barloghi. I don't play him on television, but it is my goal to try and eliminate this disease, as I think it is everybody who works on this disease in the community or in an academic center. And so how do you define it? Well, this is actually a patient of Ken Anderson's, who you all saw yesterday, who said curing myeloma is living long enough to die of something else that has nothing to do with their treatment. And that's certainly one of our goals. That is an important goal. Now, I've spent a lot of time telling you how great I think we've worked as a community, but I think it's important for everybody to realize there's a whole team of people behind you as the patient. There's a whole team of people behind you at the IMF. And at each of our individual institutions, it's not one or two people. It's a long list of people that work together to try and eliminate this disease. And I want to tell you, I stand here on behalf of our team, on behalf of the IMF, and on behalf of you, because it's a large team that includes everybody in it. Thank you.
So Michael, you have some interactive questions, perhaps?
Yes, so is the
All
panel
right.
coming up? We'll do it on the way up.
So thank you so much, just before you launch into that, Sagar, for a wonderful presentation, and we will take questions in just a moment.
Scott, you want to pull up 3, please? Well, okay, there we are. So you know the drill. You have your keypads. We have a couple of questions about transplant. So we'd like to know what has been your personal experience with transplant. 1, if you've had a tandem transplant. 2 transplants. 2, if you've had a single autologous transplant. 3, if you've had an allogeneic or a donor transplant. 4, if you've had a mini allo transplant. 5, if you've harvested your cells but not used them yet. Or 6, if you've not had a transplant and you've not harvested. How's that for a mouthful? Wait till we hit 100. There we go. Okay, so what is that now? So about half of you have either harvested or had a transplant, and 40% have not had anything, no harvest, no transplant.
A few have had a double.
Yeah, 10% double, about a third a single. No one with an allo or mini allo. Okay. Now we'll take a quick look at these numbers versus, sorry?
Sorry, I had a mini allo, but I had a tandem also. I was in the tandem group.
Ah, okay. So if you look here, we've arranged what you just told us by how long ago you were diagnosed. So in the group of longer-term survivors, we have, what, 60% of the people have had some kind of transplant. In the 2 to 5 years, it's about the same. So, and the two years or less, there are probably a lot of people who haven't gotten to the point of having the option to do a transplant. They're still doing induction. So not a big breakout there. Okay, so here's an opinion question after listening to the eloquent Dr. Lonial and others. How important is auto transplant in this new setting of novel therapies, new drugs, and combinations? 1, if you think that transplant's still very important, if you can do it. 2, if you don't think it's essential, unless the other therapies don't work. 3, if you think that you really don't need to consider it as part of your first treatment. And 4, if you think that it's better to do it after you've relapsed. People are thinking about coffee.
It won't hurt my feelings.
Few more thoughts here.
Okay, here we go. Come on, press those buttons.
Yeah, all right.
Okay, so, wow. So it's about split half and half.
Very important.
So next time you'll come back and do the other half of the job of getting the message across.
So very few people thought that they should do it at relapse.
Right. Okay, so the other question, what do you think about the maintenance question? After you're transplanted, should you be on some kind of maintenance? Those last 5 people, I don't know. Okay. Oh,
All right.
Oh.
Strong maintenance group.
There you go. I think that might be the last question for this segment. Yep. We can go back to logo.
All right.
And you're on.
So thanks very much, Michael. Very interesting to see the perspective in the room after Sagar's talk. So we have time for questions. Perhaps if we can bring the lights up for this segment.
Your question right in the back.
And I can just ask Dr. Kyle, if you want to come up, you can join us on the panel for these questions.
Okay, hit it.
This is not on.
Yeah, it is.
You can hear me?
Yeah.
Okay. My name is Pete Natali. I don't have an orange cap, I have a red cap. Can we make that clear? Okay. Okay, kind of pink. Okay.
Is that Louisville red?
Coral.
Or Syracuse orange?
No, 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 no. Miami Heat red.
Oh.
Okay.
Those
Keep
are
that in mind. Okay.
Those are fighting words.
Yeah, absolutely. My question is for Dr. Lonial. In your presentation, you have a slide, and I'm hoping you have a reference for that slide. It's the one that shows the 6 graphs. You have, I think, progression-free survival on one side and both.
From the Dutch group?
I'm not sure. I can't tell from the slide itself.
Was it towards the end in the maintenance section?
With the Velcade maintenance, with the brown curves?
It's right after the slide that was PAD versus VAD.
So that's Sonnenfeld et al. In JCO.
So that's Sonnenfeld and JCO 2012?
I think so. I think so.
Right.
Very good.
Yeah, so the lady beside you, Debbie, can help you track that down. We can definitely get that to you.
Wonderful. Thank you.
Okay.
I just wanted to get a reference to the slide.
Thanks for coming up, Dr. Kyle. Okay, yeah, it's this one here, yeah. Journal of Clinical Oncology, and someone with really good eyesight can read that at the bottom there. JCO 2012-30-2946. Okay? Another question?
All right, Danielle, anybody in your section? Danielle, you want to get the...
Right here in the middle.
Okay.
All right.
They're coming to you, sir.
I would like to look into a IMiD and a proteasome inhibitor. I wasn't able to take Revlimid very well. It lowered my blood count severely where I had to have transfusions. Is it possible for me to have, now I'm taking Velcade and Dex right now, is it possible for me to have Velcade, which is a IMiD, in a lower dose, or does it have to be the standard dose to give you the effect that you're looking for?
All right, so I think the question is, could you get benefit from Velcade but with a reduced dose of Revlimid because you had problems with the full dose, is that right?
Correct.
Absolutely, absolutely. I mean, remember, the reason I spent a moment or two on that performance status part of the benefits of a good induction regimen are that we don't want you to be sick or having lots of side effects. So if you have to reduce doses of drugs to get there, that's okay. I think that's appropriate.
Fine. Okay, good. All right. All right.
I wanted to ask the panel what the role of allotransplant and the role of mini allotransplant, if you could discuss that a little bit.
All right. The role of allo and mini allo. Sagar, you want to take that first, perhaps?
Oh, you may have asked the wrong person.
Well,
I think that the role of allotransplant is currently being explored and defined. Outside of large clinical trials that are trying to evaluate its best patient population and timing, I don't think we know the best place or patient for an allotransplant. But there are studies that are going on to try and help us identify that.
right. So, Bob, how do you feel about allo, mini allo?
Yeah, the conventional allo, there are very few persons who would want to do a conventional allo in a patient with multiple myeloma. And the so-called mini allo data has been published, a study of over 600 patients, and the mini allo results were very disappointing. So today, I don't think that very many people would be doing a mini allo or a conventional allo. The place that one might be considering it would be in the very young person with multiple myeloma with adverse prognostic features.
Right. I think the panel would agree on that. Plasma cell leukemia or high-risk cytogenetics, something like that. But also still in the context of a clinical trial at this point. Yes?
That's where I think it probably should be limited. Yeah.
Yes. Okay.
Okay, I'm going to... Okay.
Hi, Dr. Kyle.
Yes?
I was considered a high-risk patient, but I was fortunate to be considered for the MLN 9708, in which I got complete remission to 0%. And my doctor has me on no maintenance at all. And I was just wondering, is that normal practice or something you would suggest? He said we could write it out and see because I had such good response.
I missed quite a bit of that.
Right, okay, so this lady, I think as part of a frontline therapy, was in a 9708 study and has done very well, but is currently on no maintenance. And her question is, since she had some high-risk features, maybe she should be on maintenance. So maybe Sagar, I know you have the 9708 study. You want to comment on that?
Yeah, so I think that there are people that have clinical high-risk disease and there are people that have genetic high-risk disease. And for both of them, I think the question about maintenance is an important one. What I worry a little bit about is patients that have a great response and then come off all therapy, including not having a transplant. It sounds like you didn't have a transplant either. I think if you're going to delay the transplant, so with that curve that I showed you at the top, those are all patients that went on and received additional therapy after collection of their stem cells. I think being satisfied with achieving a major response after 4 or 6 or 8 cycles of therapy and then stopping completely in a patient that doesn't have symptoms, without having all the information, I can't say right or wrong, but it would make me a little nervous.
Yeah, so I think I would certainly agree, certainly to discuss the maintenance with your doctor. I think it's something that's to be reviewed carefully, in my mind.
Okay. Our next question right here.
No. Is it if you have not been able to get enough stem cells in a harvest, is it ever possible to do it in the future and get enough stem cells?
Well, we do have some newer approaches to harvesting, and actually I don't think that, Sagar, you touched on this today. Do you want to comment about some of the newer harvesting?
Yeah, so there are a couple of things, this drug called plerixafor or Mosabil, which can significantly increase poor mobilizers to get a stem cell graft collected within 1, 2, 3, or even up to 5 days. I will tell you, at our center, we probably mobilized close to 200 myeloma patients, maybe a little over that, and I think we had 1 failure last year. So it's rare for us to have a patient that we can't collect at all. It does happen, but it's pretty rare because of drugs like Mosabil.
Yeah, so I think this plerixafor, did you have this plerixafor? Okay, so that is unusual. I think that the main thing that comes to my mind is that there could, and this might be worthwhile checking, is to see if there is some element of the regular bone marrow is just not 100%, maybe some underlying MDS possibly. And the important thing about that is if the underlying marrow has some early MDS or borderline MDS, it's probably not a good idea to be doing the transplant either. So.
Okay, Debbie?
All right.
Yeah, I saw that that half the people here, I think, were saying that they thought that the transplant option would probably not be necessary if we had enough good response from novel drugs. But I'm currently trying to find a place to let me collect and store. And Moffitt, I was told, won't collect and store. They'll only collect stem cells if you want to do the transplant right away. Okay. And I'm having a hard time finding a facility that'll do collect and store.
Okay, very important. All right. So I think Dr. Kyle's going to store them in his freezer at home for you. No. So, no.
No, we store patients routinely, and the stored cells can last for at least 15 or 20 years. The problem is that the institution may run out of freezer space, actually, and that can be a problem depending upon the institution. But I think by and large, it's a very good idea to have stem cells in the freezer for future use, because we cannot, despite the novel agents, we cannot look the patient in the eye and say, you will be cured with this or with this combination of agents. And so I think it's a very good idea for a person who is potentially transplant eligible to have those cells in a freezer and available.
Right, but it can be, there are some centers that won't, and also there can be some insurance issues too. So what's your experience, Sagar?
Yeah, so we've not had an issue with being denied that. We've not had an issue with the IFM study either, where we have to give them the protocol ahead of time and get them to approve early versus delayed. So I think I've heard of centers that have trouble with it. I guess what I would tell you is, other than Coca-Cola, Atlanta's also known for Delta. And all roads, even to Rochester, come through Atlanta now.
Come through Atlanta. and the harvesting machine will be tuned up and ready.
That's right.
Okay, Danielle.
All right.
Danielle, in your section?
Hi, my name is Emil Herkert. We're caregivers for our son who has tandem transplants, has had tandem transplants. He had 2 induction therapies before the first transplant. And he's presently receiving no maintenance therapy, only Revlimid. My question goes to the issue.
Only Revlimid?
Not Revlimid, Zometa. The only thing he's getting at the moment is Zometa.
No Revlimid. Okay.
No Revlimid, sorry. And my question goes to the issue of should he be considering maintenance therapy during this time, and would it help?
Okay, Sagar, you want to take that first? So after a tandem transplant, what is the level of the response? Do you know? It's been an excellent response, I think, right?
It's been a very slow, steady decrease in his numbers, but no great drop-off.
Okay, so there's still some
active
myeloma
in existence. That's the reason why he's getting the Zometa.
Okay. So what do you think, Sagar?
Well, I mean, I think, in my mind, the people for whom it's hardest to really push for Rev maintenance are patients who have standard risk disease and are in a CR after their transplant. That's the one where the risk benefit that I showed you over there, I don't know that it's quite as clear as it is for all the other patients. We do it, we recommend it, but I don't disagree with a patient if they say, leave me alone, I don't want anything. So I think if there's residual disease, that's somebody I would favor Len maintenance in, but without all the specifics of that case and what that patient has been through, it's hard to really make a clear recommendation.
Right. But certainly if there's residual myeloma, I think we would certainly be thinking about it.
I would. Dr. Kyle may disagree.
No, I think it's certainly a consideration, and in a situation as complex as this, one would need to go over the record very carefully and look at the patient, and after discussion make a decision.
Right.
Okay, Kelly, you having a question over there?
With all the studies and everything that I'm seeing that are going up there, I don't see anything that's breaking stuff down as far as if it was stage 1 or stage 3. I believe that there would be a big difference if you had 25% myeloma in your marrow to 80% myeloma in your marrow.
Okay, so this is a good question. So with these novel therapies, what do we truly see as factors that make a difference headed into these novel therapies? What impact is there with stage, or what are the factors?
Well, I think for the stage 1, a number of those patients would have smoldering multiple myeloma, and we in general would not be treating those patients. I think that there are other factors that are more important than the stage per se, particularly the cytogenetics and probably the gene expression profiling.
Right. There is one thing, the IMWG, the working group, we did recently analyze the fish testing. So we're obviously paying attention to the fish if you have the 17p minus or the 414. And we looked at that with respect to, was it stage 1 or stage 3? And so we did just publish this in Leukemia, actually. This was Hervé Avelasso from France. We did this together on several thousand patients. And so what we did find is that there is a difference if you have the 17P and it's stage 3 or stage 1, it does make a difference. And so I think that we shouldn't ignore that even in the setting of the FISH testing. So but we don't often show the curves.
I think it's challenging because typically when we talk about staging cancers, we think that the stage relates to bulk of disease. If you're a stage 4 lung, you have a lot more than if you're a stage 1 or a stage 2 lung. If you're stage 1, you cut it out and you move on. I think that in myeloma, staging doesn't refer to that. Staging refers to how fast the tumor cells are dividing. And so stage 1 versus stage 3, the reason the outcomes are different between 1 and 3 is that 3 tends to be a more proliferative myeloma. And so it's proliferation and genetics that are probably more important than the stage in terms of deciding outcomes.
Right.
Okay.
So they're all important.
I would also point out to those of you in the audience who have an MGUS or a smoldering myeloma and have the adverse FISH features, we don't really know how big a role that plays, the abnormal cytogenetic features really play in going on to develop multiple myeloma. Certainly, after you have symptomatic multiple myeloma, then the cytogenetic features that we see on FISH are very important from a prognostic standpoint. But prior to that, and I would also point out that I at least was very shocked to learn several years ago that patients with some patients with an MGUS actually had these adverse cytogenetic features, but then nothing seemed to happen to them. So don't just hold your breath if you fall into that small category with MGUS and say adverse cytogenetic features on FISH.
So one final point is that in the IMWG paper, Hervé looked at ISS and then tumor burden and FISH, and actually all three are important. So you need to know the amount of the myeloma, is it growing rapidly, and the FISH. Those three you need.
Okay, we're going to take two more questions. We're going to start with Suzanne, and I have the last question over here. But keep in mind, those of you who haven't had your question answered during this session, in the afternoon you're going to go into your breakouts. There'll be plenty of time for more questions. So Suzanne?
Okay, this lady right here with the microphone.
I have a question on Revlimid specifically. Is how any of you or how often have you found patients responding that their platelets become lowered with a maintenance Revlimid? Is that common, uncommon, and going from a higher to a lower dose being a common change?
So maybe Sagar, obviously this does happen. So Sagar, what's your experience?
Yeah, I mean, we see it, and it usually occurs as patients have been on drug for a longer and longer period of time. And in that situation, we do reduce the dose or change the schedule. When I use maintenance Rev, I don't do it continuous dosing like the trials did it. I do it 3 weeks on with a 1 week break. Because I think that 1 week break is really important for blood count recovery, and that has often helped platelets in patients. But if 10 is dropping the platelets too low, and I don't have a number to tell you what that number is. For me, it's sort of a feeling, like I've seen the last 3 months, the platelet count at the beginning, it was 150, now it's 130, now it's 85, now it's 60. That to me is a reason you need to think about dose and schedule changes.
Right. So reduce the dose for sure, because if it is maintenance, which means it's going to continue. So you got to back off.
Okay. Our last question for this session.
Yes, I'm Alan Hunter, and I've had a stem cell transplant, and I was told that when I had it, I lost all my childhood vaccinations.
Okay.
Is there any point in time when you can have them done over again? I'm over a year and a half out on the transplant.
Sure. This varies from center to center, but a lot of centers do. So what do you do in Atlanta about that?
So we revaccinate at 1 year. We start at 1 year, and I think that's the CDC guidelines as well.
Right.
Agree. Some patients we will revaccinate at 9 months, but generally speaking, 1 year is sufficient.
All right. So thank you for that. A lot of good questions. Thanks again to Sagar for bringing up this topic. Okay, so the final topic for the morning is maybe the simplest topic. So I'm going to finish up by just going over some of the details about bone disease. And so really, when it gets right down to it, there are two questions about bone disease. One is, do you have it at the beginning or during the course of the disease? And then number two, what are we going to do about it? So do you have it, and what can we do specifically for the bone disease? Okay. So the first thing I mentioned already in the introductory talk is that we have really seen a shift in the way that we evaluate bone disease. And so the traditional way to look for a myeloma lesion is on an X-ray, and this is the sort of thing that you can see on an X-ray of your back, of your spine. It shows this area, the dark area, which is a hole in the bone which has been destroyed by the myeloma. In this kind of a picture, the white is the strength of the bone, and you can see that it's been weakened by this lesion, and you could see there might even be a tendency for that bone to collapse, and when it does that, it collapses forward, and that's why you get something which is called kyphosis. And so when myeloma affects your back, the vertebrae tend to collapse at the front, and so that increases the curvature of your spine, and that's something that happens with older people. You get osteoporosis, and the exact same thing happens. However, we are trying to diagnose bone disease earlier. We want to be able to pick it up on a PET scan. This shows you the sugar uptake. When you inject a small amount of sugar, it will go to the active areas in the middle of the bone, hopefully at a point before the myeloma has grown to the point where it's actually damaging the hard part of the bone, the cortex of the bone. And the same thing on an MRI. On an MRI of the spine, you can see it here. This is the spinal cord, by the way. And so you can see it's right behind the bones, and so that is one reason we're especially anxious to make sure there's nothing serious going on with the bones, because it can move forward, it could move back, and we certainly don't want that. So these are more sensitive techniques, and we definitely focus on that more now in terms of diagnosis. And so at baseline, around about 65% of patients will in fact have some changes on bone. These days, the number of patients who really have extensive lesions on bone has been significantly decreasing. In the old days, it was only probably 10–15% of patients where if the x-rays were negative, we would pick up something on a PET scan or an MRI. But this is kind of shifting. As we diagnose myeloma earlier, we see perhaps fewer patients, and it's more like a 50-50 split now, where we might find maybe half the patients have changes on x-rays, and then the other, if we're going to pick them up, we'll find them on a CT or a PET CT or MRI. And so we're seeing that shift there as well. And so a key message here is if x-rays are negative, and so if you've been evaluated for myeloma and the x-rays are negative, these days that's probably not enough. At least one time at baseline or along the way, you should be getting some extra imaging done just to make sure that there is not some bone problem hiding somewhere. So, bone density. This is a common question. Should you have a bone density test? And a lot of people have actually had a bone density test because of the age incidence of myeloma. So many people have had a bone density test because of their age, especially if you're a woman. And so a reduced bone density can be due to myeloma, but it can also be osteoporosis, which can be something related to your age. But a particular reason that we need to pay attention to bone density is that dexamethasone or prednisone, steroids that we use as part of the treatment, can increase the osteoporosis. So Myeloma patients have two issues with their bones. Myeloma can damage your bones, but steroids can also damage your bones. And so if you're staying on a lot of dexamethasone, you could be getting osteoporosis because of the dex. And so actually, it's important for myeloma patients, I believe, to have a bone density test so that we have some sense of this, and then to check it periodically to see, are they getting improvement in the bone lesions from the myeloma? Is there more effect from the dex that we need to be aware of and potentially treat that? So about 80% of patients will have bone problems that we need to be paying attention to on X-ray with focal lesions or diffuse changes. The things that are important about that are obviously there can be pain, there can be fractures, because especially in the spine area, those bones are very close to the spinal cord, and where the nerves are coming out of the spine, we need to be very alert to possible pressure on the nerves and the spine. And this is very similar to if you have a disc problem. If you have a lumbar disc, the reason that it hurts is that you've burst the disc between your vertebrae, and then it's squished out and is pressing on a nerve. And so we need to be very alert to that, and there are different ways of handling it. If you have a lot of bone destruction, this releases calcium into the blood, and so that's why we have increased blood calcium. And so normally in the CRAB features, the CRAB, if the calcium is elevated, that would be typically because you have a lot of bone disease and the calcium is released into your blood, causing an increased blood calcium. Now, what about the PET scanning? What is the new information related to the PET scanning, and how are we starting to use the PET scanning to pick up bone involvement, and what does that mean? And so there was quite a helpful paper that was published in Blood by the Italian team from Bologna in Italy, Dr. Elena Zamagni, and so she did a very nice study where she looked at the PET scanning, and this was after the first therapy had been given. And so she asked an important question. And so it's interesting that important answers usually come from important questions. so it's important to ask the right question, and then you might get a good answer. And so she asked a very good question, which is, if you've had your first therapy, let's say you've had VRD, and then you had a single autologous transplant, is the myeloma gone or not? And so she asked that question in the context of the PET scanning. And so she said, okay, if the PET scanning is negative, and she did that 100 days after the transplant, how does that look versus if it's not? And so she found out that if the PET scan is negative, and there's a CR, then there's a much greater likelihood that the remission will last versus if it doesn't. And so this is quite a good time to think about getting a PET scan. If there's myeloma remaining, it's a good idea to know about it. It could be enough to say, well, perhaps we should be thinking about maintenance, for example, a question that just came up in that last session. You can also do this with MRI. This is less commonly done in the US. For some reason in Germany, they have access to what's called wide field MRI, and so they can do MRI of most of your body. And so Dr. Hillengass in Heidelberg, Germany, he looked at post-transplant. So it was the exact same question, is the MRI negative or not? And he looked at the number of lesions, 1 to 10 or greater than 20. And so you can see here this blue one. That means that there were more than 20 lesions still left after the transplant, and obviously the remission was much shorter if there were still obvious lesions on the MRI. And so this is an important way to evaluate not just do you have bone disease, but what is the status after you've had what would be your maximum attempt at achieving a good remission. This shows you what happens over time with MRI, PET scanning, and also with measurements of the protein level. So at the bottom here, you can see the M protein in this particular patient between January and April. You can see the myeloma protein came down very close to a CR, very VGPR. And during the same time frame, between January and April, the PET scan went from all these lesions negative. So there was, you can document this type of improvement. The one thing I want you to be alert to is if you're getting PET scans or MRI, the MRI improves much more slowly. You shut down the activity of the myeloma, but on the MRI, you can still see that the myeloma is there. It's still kind of getting dissolved and resorbed and cleared out of the marrow. And so if you look at the MRI, this is the dark spot here, and you can still see it later. That it takes time for the MRI to get better. And so if you have a follow-up MRI after 3 to 6 months, you should not be so distressed because it takes longer for it to clear up. And so if you look at the MRI versus the PET scan gets better, as I just showed you. Within 3 months, the PET scan's getting better. But it takes 6 months out to a year or longer. These are data from Little Rock, actually, where they have very good data on imaging. It takes longer for the MRI to show the benefit. You can see the curve really starts to go up after a year to 18 months. That's when the MRI really finally can clear the myeloma out of your bone marrow. So it's helpful just to be aware of that. A key point, especially these days, is, strangely enough, if you want to limit the amount of bone disease and even to prevent the bone disease, the best treatment is treat the myeloma. When you treat the myeloma is not triggering bone destruction, so you're not going to get more bone damage. And I think that for me, this is one of the things that has transformed the approach to myeloma therapy, is that yes, we have the drugs for the bone disease, which I'm going to show you in a second, but with the better therapy for the myeloma, you heard from Sagar that with these VRDs, the response occurs within the first 2-3 months. The myeloma is really shut down. And so what that means is you are not getting new bone damage at that point. And so the best preventative for myeloma bone disease is good treatment for the myeloma. If there is a spot where the myeloma has really created a problem, particularly if it's pressing on a nerve, it may be urgent to treat it with radiation. But in general, we prefer to avoid the radiation if we can. And then, of course, I'm going to go through what are the specific things that we can do for the bones. So radiation, we use it for severe pain control, especially if the treatment is not working well, if there's pressure on the spinal cord, and to try to prevent a pathologic fracture. But in the red box here, we prefer to avoid it because the radiation wipes out the myeloma. However, it does also damage the normal bone healing process in that area. And so, yes, you got rid of the myeloma, but in that spot, the myeloma may not heal up as well as you might like. So, if you have collapsed a vertebra, or it looks like a vertebra is going to collapse, there is a procedure which I think has made a huge difference and is an important benefit for myeloma patients, and that is the kyphoplasty. And so, I think we asked this later. How many patients here have had a kyphoplasty done? Just to give me an idea. Yeah, so more on my left-hand side of the room, not so much on the right. Anyway, about a dozen hands shot up there. So there are two parts to the kyphoplasty. The main part is that you're injecting cement into the vertebra to stabilize it. In the case of kyphoplasty, what you do is that you put this little balloon in there first. So you have this balloon, and you blow up the balloon, which opens up a space, a very nice compact space, where you can inject the cement. And so you fill the hole with the cement. And so there are two very key aspects to that. When you use the balloon, it compacts the space around the hole, which means that when you inject the cement, it will not leak out. So since this is pretty close to your spinal cord, this is really a good thing. The other thing is that when you open up that balloon, and you can see it on the slide there, you can see here that this is kind of reduced because it's collapsed. When you inflate the balloon, it opens it up a bit, and so you can have some recovery of the height of the vertebrae, so you can get some straightening of your spine. And so this is also a helpful part of the kyphoplasty procedure. And then obviously the final part is the cement strengthens that vertebra. The one thing that we need to be cautious about that is that this actually is the strongest vertebra in this part of your spine then. So this is really a strong vertebra. So it actually puts some stress on the ones above and below it. And so when we monitor, we usually have pretty good success with that one vertebra. But if there's any weakness in the one above or below, we keep a close eye on that, because it's possible over the next few months we might want to treat the one above or below just so that we strengthen that whole area. There is another procedure which is vertebroplasty, which is basically the same thing, where you inject the dye into the area without creating the compacted space. And you can see what happens there. You see it's a much more diffuse. You've injected it here, but it's much more, it's going around there. Now, if you do this procedure, it's extremely important to make sure that the vertebra is still intact so that the cement would not, in fact, leak out. And so this is a very effective procedure, but it's very doctor dependent. I mean, the doctor who does this needs to be experienced in selecting the patient and with where you inject the cement. And if it's done properly, though, the results are really quite good and can be largely comparable to the kyphoplasty. So beyond treating the myeloma, the one type of drugs that we have is that many of you have been taking are the bisphosphonates. And we use those because of studies done about 15 years ago that showed that this reduces what we call skeletal-related events, what are called SREs. And if you look at myeloma papers, you'll see that acronym used a lot. What that means is collapse of a vertebra or a fracture or an acute problem with a bone. So if you use the bisphosphonates, it's found out that you have less problems with your bones, basically. And it's recommended for patients who have ongoing therapy for their myeloma, most of whom have bone disease. There's a little bit of a controversy about should every patient with myeloma be getting these drugs, or just the patients that have the bone disease. And so for patients who have x-rays that show bone lesions, that's pretty clear. Then you move down into patients where there may or may not be bone disease at the same level. So if you have an MRI, if you have a CT PET scan, if you have more than 7 lesions, this is a cutoff that we use. If you have multiple lesions on the MRI, chances are that the myeloma is starting to damage the bone. And obviously, if the CT scan shows damage, then you have bone destruction. And so this is a group of patients where we would definitely use the bisphosphonates, the Iridia or the Zometa. That's what I'm talking about, Iridia or Zometa, which most of you are taking. If you have 6 lesions on MRI, should you be getting bisphosphonates? And this is where the questions come up, and there's some mixed opinions. Some people would say that there's enough risk of bone disease that we should be using the bisphosphonates, especially Zometa, across the board. Other people would say, well, not so fast. And so this is an area that we could discuss. If you have reduced bone density, then if we think it's due to the myeloma, we would also use bisphosphonates. There are now fairly detailed guidelines about the use of Iridia and Zometa. In general, these are pretty safe drugs, and so for a long time we used them in a relatively nonchalant way, I would say, is that patients would come in once a month, get their bisphosphonate, and go home. It was a good time to get caught up with the newspaper and chat to some people in the treatment area, but basically fairly safe. But then we've realized that maybe there are some things that we maybe should be paying some closer attention to. And so now we're looking at, should we be giving you the bisphosphonates? How long should you be taking them? Which one should you take? And are there issues with kidneys or teeth that we need to be reviewing with you? And so we now know that we need to be looking at those 5 things when you're taking Iridia or Zometa. So the first thing is that most people would say is that they should not be given in an open-ended fashion across the board. We should be looking at what is it best to do after 2 years. If you've had an excellent response and there's no more evidence of bone destruction, should you be continuing to take it? And I think that many people would say it's reasonable to stop. The reason to continue would be some evidence that Zometa, just by itself, could give some slight improvement in overall survival. And this is really just from one study in the UK, the MRC study. I think that most people would be looking at either stopping or at least reducing the frequency after 2 years. This is particularly true with the Zometa, but as far as efficacy, I think most people would agree, as far as the bones are concerned, you could be taking Iridia or Zometa. And we'll find out that percentage with the interactive when we finish. With Zometa, there are the increased toxicities of, particularly of the osteonecrosis of the jaw, which I'm going to touch on. But these are largely preventable now because we are aware of them. The time of administration is the main difference between the practical use of these drugs. So the Iridia, pamidronate, is given over 2 to 4 hours. It's a 90 milligram dose. There are some data from Europe, from Scandinavia, that we could conceivably look at even a 30 milligram dose there, but I think that traditionally in the US, that is a 90 milligram dose. For the Zometa, it's a 4 milligram dose over a much shorter time frame. I tend to give it over at least half an hour just to be safe about the infusion time. Again, if there's some issues with the kidney, there are schedules to reduce the dose down to 2 milligrams, for example, and you can change the infusion times in the schedule. This is just, sorry to do this before lunch, but anyway, this is better than showing you the real thing, which we've sometimes done. But for osteonecrosis of the jaw, it's important to realize that it is osteonecrosis of the jaw, and it's something that is affecting the area underneath the teeth. So these are your teeth right here, but it's an area underneath the teeth that is getting affected. And so this is important to be aware of, because if something's happening there, it would make the tooth loose, it could make the gum underneath swollen or painful, maybe even more susceptible to get infected. And so if there's something going on underneath the teeth, this is something to be aware of before it gets to be more of a problem. And so something to alert your doctor to. And so actually the strange thing is, this is something that can occur even in someone who has lost all of their teeth. So let's say someone's had all their teeth pulled out for some reason and they're wearing dentures. They can still get osteonecrosis of the jaw. It's a problem of the jawbone itself. Now, the IMF, over 10 years ago, with Mike Katz and myself, we did a follow-up survey when it was first realized that this could be a complication. And we asked patients if they had developed this osteonecrosis problem, and we also asked them if they were taking Zometa or Iridia. And so what we found out, which is subsequently being confirmed all around the world, is that if you've been taking Iridia, it actually takes quite a long time for any likelihood of this osteonecrosis, which is why we'd never seen it up to that point. But what we realized is that if you're taking Zometa, it's much more likely to happen sooner. And at 1 year, it could be around 5–7%. And so this is why we were suddenly starting to see more of it. And so this is where the decisions about, well, how long should you take the bisphosphonates, this is where that information came from. You can see here, you could have a cutoff of 1 year where you would be pretty safe. Well, for Iridia, it would be really safe. And for Zometa, it's still pretty safe. If you go out to 2 years, the numbers are starting to go up. And if you go out to 36 months, the numbers are definitely going up. And so if you want to stay on the safe side, you can see it's very much influenced by the time. So what do we recommend? If you have a problem with your teeth, you should fix them before you start on bisphosphonate therapy for myeloma. That's the bottom line. So you should get your teeth checked. This is a crazy thing. You go to the blood doctor, and he says, well, go get your teeth checked. But this is true, because if you have a problem, then that puts you at risk of having this necrosis. Then, during therapy, you should be aware that there's nothing bad going on with your teeth. You should go in and get checked. What you should not do is let the doctor pull a tooth out, because if you have a tooth pulled out, that irritates the jawbone right underneath, and that actually is the commonest way to really get it flared up if you get the tooth pulled. So do not get the tooth pulled. Get a specialty dentist consult, and we can talk about that a little bit. If there's inflammation and things that are painful, there are other things to be looked at. Antibiotics can be helpful, and a lot of people feel strongly that antibiotics and some minor dental procedures are the way to go just to handle this problem. And then rinses can be good, and even people have looked at hyperbaric oxygen to try to get the bone to heal up. A key thing was that the Greeks, Dr. Demopoulos in Greece, he showed 3–4 years ago now, is that if you have this awareness and you're getting your dental checkups and you're using the rinses and stopping the bisphosphonates early, you can really, really reduce the risk. And so this is basically a preventable problem. With awareness now, it's not such an issue. And that's why people are talking about, well, maybe it's not so bad to think about taking the bisphosphonates for longer. But this is not a trivial problem. And you could say, oh, well, it's 5%. Well, if that 5% is you, that is a problem. And it's not a trivial one. The final thing I want to talk about is that we have had good success in treating myeloma better. We have had good results with the bisphosphonates. So what these drugs do, what Iridia and Zometa do, is that they attack the osteoclasts. So these are the cells that are destroying the bone, but there's another type of cell which is called the osteoblast. The osteoblast, that's the cell that heals the bone. And so the problem is that in myeloma, and this is characteristic of myeloma, is that the osteoblast gets messed up. So you can treat the myeloma and you can shut down the destruction, but if you don't have those osteoblasts tuned up, then the myeloma lesion is not going to heal like it should. And so this is just to show you that there is a tendency for the myeloma to trigger through this receptor here, and you actually destroy the osteoblasts, the healing cells. And so this is an argument to treat the myeloma rapidly to stop this from happening. And then we're also looking at medicines that would trigger these osteoblasts to do a better job. And so this is kind of the new area of bone research right now. And so there are new drugs beyond the bisphosphonates, and Amgen has a new drug that I'll show you just in a second in more detail, which targets the osteoclast in a slightly different way and could be a new good treatment for myeloma bone disease. There are some other ideas about how to improve myeloma bone disease. These are in trials. I think a couple of people have mentioned that Velcade, one of its advantages is that it actually helps bone healing. And also Revlimid directly also seems to shut down the osteoclast, so that both of those drugs, not only do they attack the myeloma, they also have some beneficial effects directly on the bone. And then strangely enough, the cholesterol-lowering drugs like Lipitor also can improve the bone healing process. So that's kind of interesting. This is just to show you this new drug, which is a factor which tags in here within the chain of the activation of the osteoclast. And you can see the little yellow guy here comes in and is basically has a blocking function. So it blocks the activation of the osteoclast by the myeloma. And so this can work well. It's a little bit different mechanism. The bisphosphonates are actually taken up by the osteoclast, and then the osteoclasts end up dying. So, what do we do about myeloma bone disease? We just need to make sure, do you have it, don't you have it, and monitor closely over time. It's one of the things that we are very careful to try to avoid. You should use your Iridia and Zometa with good monitoring, with a good plan about how long are you going to take it, and under what circumstances might you stop it or restart it. And then the best way to really maintain good bone strength is to get back into some degree of exercise, which definitely enhances bone density. One issue which we sometimes don't focus on as much as we should is that if you've had quite a bit of bone disease and things are going well, you may still have pain. You may have pain just because the bones are damaged. Now, this is not due to the myeloma anymore. It's due to the fact that the bones have been damaged. It's the same thing that might have happened if you were in a car accident. You've damaged your bones. And so we often don't pay enough attention to trying to rehabilitate that. We can use nerve blocks. We can even do minor surgeries to try to get rid of the pain so that you can recover to as full activity as possible. And of course, the best way to stay in shape is to avoid risky situations. There's a few different things you shouldn't do, and this certainly would be one of them. So we recommend exercise, but we don't recommend this. What we do recommend is maybe a quiet walk in the woods be a little bit better. Even a quick jog through the woods would be fine. But just avoid things where you're liable to fall down. There would be no riding a horse through the woods, for example. The other thing about the woods is that when you've got myeloma, the last thing you want is melanoma. And so this also has the advantage of keeping you out of the sun. All right, I'll stop there. Thank you. So we have a few questions, and then... Oh, we're going to do the interactive first. Okay. So if Sagar and Bob, if you want to come up, we'll have, I think, time for a few questions before lunch.
Okay, so a few interactive questions for you. The first is, do you or the patient you're representing have bone disease? 1 for yes, 2 for no.
We'll see how correct my percentages are here.
Well, we'll see. There we go.
All right.
50-50.
47%. So maybe we are diagnosing earlier.
Could be.
How about that?
Okay. Have you been treated with 1, Iridia or Pamidronate, 2, Zometa or Zoledronate, 3, if you've had both of those wonderful drugs, and 4, if you've had none of them? Wow.
Mostly Zometa, yes.
Yep.
Captured the market.
But 80% of the folks answering have had some kind of bisphosphonate treatment, which is a good thing.
But it's interesting, 21% none.
Yes.
It is. Okay.
Okay, how long should you take Iridia or Zometa? 1 for 1 year, 2 for 2 years, 3 until you're in remission, 4, you should keep taking it indefinitely or on an ongoing basis, and 5, you don't know.
So.
People are thinking more about this one.
Yeah, that's a tricky one. Yeah.
Okay, where's number 100?
Come on, that last one.
Push that button.
There you go.
Okay. All right, so
2
you were
years.
listening.
Yeah.
52% to 2 years, which is the current wisdom, I think. And
Yeah.
the other guys, you're just wrong.
Sorry about that. Yeah, come on up, yeah.
But actually, no one really knows the answer to that question. So.
Right. It's just conventional. All right.
Have you needed or had a balloon kyphoplasty? 1 for yes, 2 for no, if you had, and you had a vertebroplasty instead, which you just learned what that is, or 3 if you've had neither procedure. So 1 if you had a kyphoplasty, 2 if you've had a vertebroplasty, and 3 if you haven't had either procedure. Nope. Took so long to answer the question. Okay, so 20% have had one or the other, roughly.
Okay, so again, it's a smaller percentage, 20%. Yeah, one or the other. Mm-hmm.
Well, hopefully we're breaking less bones in the
so
spine.
it sounds like we're having less bone disease and less broken bones.
Yeah. Okay, now we get to the ONJ question.
ONJ.
Have you been diagnosed with osteonecrosis of the jaw? 1 for yes, 2 for no, or 3 if you don't know?
So this is something that you should know.
Yeah. Okay. 6%.
6%.
Wow. Well, we have a very high percentage of people that have been out more than 5 years, so
Right.
it probably doesn't represent. We can look at that later.
But we also have a small fraction who are actually taking bisphosphonates.
Yeah.
So anyway.
Yeah. Well, okay, so here's another question. Have you had any of the following symptoms? 1, if you've had exposed bone in the mouth. 2, if you've had bone erosion around the teeth, all of a sudden a tooth is loose. 3, if you've had both of those. And 4, if you've had none of those symptoms.
Okay. Oh, more people are interested in this one. Yeah. Wow.
Okay. Okay, well, that's pretty good. But actually, if you look at the first 3, you've got 17% of people reporting symptoms that are common for people with ONJ, whereas we had a 6% rate of people who were diagnosed with it. So, I mean, it's something you probably should just have your doctor check the next time you see.
So the people who answered yes to the 1, 2, and 3 here, bring that up with your doctor and maybe have it reviewed by a dentist just to make sure what's going on there. Okay.
Okay. And I think that's it. We're ready for questions from the audience, and just go back to logo,
okay,
please.
we can go back to the logo.
Okay, we're going to
All right.
my section.
All right. So some final questions before lunch.
Robert, the lucky recipient. Here you go.
So we just switch it back to the logo. That would be good.
Hi. I recently had a bone marrow biopsy.
All right.
And I've had a couple of them over the years. I've maybe had 2 or 3 of them. Initially, when I first got it, and I've been at this a couple of years now. So, but here's the deal. I'm laying down on the table, and they're putting the needles in, and they're going deeper and deeper, and keep on asking me. I'm a Navy captain. He said, "Captain, are you sure this is okay?" I said, "Yeah, everything's fine." Well, the bottom line is, after a good deal of pressure on both cheeks in the back, they couldn't come up with anything.
Oh. Okay.
Nothing, 0.
So was this with where they were sucking? Was it also with what we call the biopsy part?
Yes.
I see.
And
okay.
so you know,
this is...
what does that mean? I don't have any marrow?
No.
You know, and I talked to the Dr. Anderson yesterday about this. He said, "No, if you didn't have any marrow, you wouldn't be standing here."
That's right. You've got marrow.
Well,
so
what does it mean?
I think the broad answer
I do have osteoporosis.
would be technical error. I think that there is one aspect. Sometimes the myeloma bones are so soft that sometimes when you pull the needle out, it just slips back out of the core needle. But that's relatively rare. And so how often would you say that you have this where on both sides you're just not able to get a sample? That's pretty rare.
I mean, I think it may have to do probably with the angle of the needle when it went in. So if you think about it like a pool tape, like a billiards ball, right? If this is the ball and the needle is coming in at the top, you may skim through the top, and you may not get to the marrow, which is in the middle. So if the angle of approach doesn't get through the periosteum into the marrow cavity, you'll see a marrow that doesn't show you anything.
Right.
Doesn't mean you don't have marrow.
It could be.
Yeah.
I mean, there is an important gap. The pelvic bone comes down like this, and then there's a sacrum in the middle. And so there's a gap between there where there actually is no bone. And so the needle could skiff off and then go where there is no bone. That's possible.
This went on for about an hour.
So maybe it's my goodness. At the Mayo Clinic, I mean, maybe you could comment, Bob. At the Mayo Clinic, there's a special service for the bone marrows where the technicians are doing the bone marrows all day long. And how often do they not get bone marrow, Bob?
I think that this has to be a technical problem. When you do a aspirate and biopsy, you would always get some bone. You may be sampling an area in which there are no cells, but you would always get bone. And so I think that Dr. Durie's initial answer, that is that there is a technical problem, is the answer here.
All right.
Okay, we're going to go to Debbie.
Sorry about that.
Debbie in the back.
I take Revlimid and Dex. I've been taking it for over 4 years, and when I take the Dex in the morning, that night, I can't sleep at all. And someone had mentioned Biaxam. Do you know what that is, and could you tell me what that is?
Okay, so Biaxam is an antibiotic. It's also called clarithromycin. It's actually part of a regimen used by Dr. Nesvitsky called the BIRD regimen and the BLTD. It actually can make the effects of the DEX more. So if you were to take Biaxam with the DEX, it might actually accentuate the impact of the DEX because it affects the metabolism of drugs actually. And so Biaxam wouldn't be something that would help. Okay, it could potentially make it worse, or it might have no effect at all in terms of the impact of the DEX on you. The DEX is obviously a problem, sometimes taking it different times of the day. Strangely enough, sometimes people can take DEX. We tend to recommend take the DEX in the morning, but actually, sometimes if you take the DEX later in the day, people can tolerate it better. They can sleep through it. I don't know. Any suggestions about how to get around this impact of DEX?
I think it's pretty much an individual sort of thing. Some patients are affected greatly by DEX, even in small doses, and others seem to tolerate it better.
Yeah, I guess the question is, do you need that much? Can you go down?
You can use less.
Yeah.
Okay.
Less. I mean, we have learned, not only have we gone to, and people ask this question, so we went from what we call high-dose DEX to low-dose DEX, which, now the high-dose DEX is 40 milligrams for 4 days in a row. The low-dose DEX is 40 milligrams. And so people say, well, actually, it's not lower dose, and that's correct. It is actually the same dose.
Yeah, but Brian, with the higher dose, there were so many more homicides.
Anyway, it is the same dose, but it's just for less days. But this point that Sagar is making is an important one. I think that we've also learned that the 1 day less is effective. 20 milligrams, lower doses I find work very, very nicely. So reducing the dose is a good idea. Okay.
Danielle?
To know if you recommend taking calcium if you have osteopenia and you don't have any signs of bone lesions?
Yes, I mean, this would be the, okay, I actually didn't talk about, I think it might have been on one of my slides, but I didn't discuss it. So I think that we would recommend calcium, and also vitamin D levels need to be checked. So one aspect which I didn't flush out on my slide is that we've learned that vitamin D levels can be low in myeloma patients, and so it's a good idea to check the vitamin D level to see if you need to take extra vitamin D. And I think that most of us would recommend some calcium supplements. And so, do you guys recommend calcium and checking vitamin D? Yeah.
Yes, 1 gram for men and 1.5 grams daily for women.
Women with the calcium.
And yes, and vitamin D as well.
Vitamin D you would use
nothing more than 1,000 units.
1,000 units.
Less actually is fine, but no more than 1,000.
All right. Okay.
All right, Kelly?
All right.
My question is, I was on Zometa for 3 or 4 years, and I was getting it about every 3 months. Does it dissipate? Do the effects of it dissipate over time? I haven't been on it for a year. So
they dissipate slowly. So this is an important point, is that if you do not have any new active bone disease, the Zometa does actually stay in the bones for a long time. It has a half-life of about 10 years, actually. So it stays there for a very long time. And so that's why we say that you can decrease the frequency, even stop, if you're in remission. Because if you're not getting any new bone damage, that Zometa is still there for a very long time. Okay?
And is there any way to measure whether the Zometa has done something? I was told by an oral surgeon at Shands that you could evaluate some part of the jaw to see if actually you were predisposed towards ONJ.
Yes, I mean, there are some more sensitive imagings. I mean, if you're having tenderness or some questions about the jaw, I showed you the x-rays, but you can actually do you can do PET scanning, you can do MRI, you can look in a more sensitive way to see if there's something going on in the jaw. The other test that we don't use a lot, because it's not 100% reliable, is that it was on one of my slides, is you can use this test called NTX, which is a test which reflects the turnover of the bone. And so you can see if the bone is still metabolizing, and you can do that by picking up these things that come out in the urine. And so that can be an indicator. If you still have bone turnover, then maybe it's worth to consider taking Zometa. And if the NTX is 0, then you probably don't need it. But those are not 100% reliable, and we mostly don't use those routinely.
All right, Suzanne?
Lana Franklin, I'd like to address a gentleman who commented about not being able to have your stem cells stored. Mine are stored at Moffitt with no transplant.
Okay.
And I also know, at least 3 years ago, that Atlanta would take me and my stem cells if I needed a transplant.
Great. Well, these are two wonderful things. Yeah. No, this is great. So we can tell right away, you are very persuasive. And so...
Well, it really did take a lot of persuasion. It did.
This is the recommendation, persuasion. Have this lady go over with you.
Well, I'm there every other month. And just FYI, also, if it were the other way around, if I had had my stem cells stored in Atlanta, Moffitt would not have taken them.
Right.
We'll take theirs, though.
I know.
All right. Thanks so much for that comment.
We're going to take one last question for this session, and it's this gentleman right over here.
Okay.
Thanks, Susie. Dave McMullen. You mentioned, Dr. Durie, that after 2 years without active bone disease, you would normally stop bisphosphonates.
Yes.
or continue at a reduced frequency.
Right.
So under what circumstances would you or the other doctors recommend stopping entirely versus continuing at reduced frequency?
So maybe I can comment, and then one of the other two can. So if you're in a complete remission, and if you had limited bone disease to start with, for example, I would be inclined just to stop. The flip side would be if you had extensive bone disease and you were maybe not in a full remission, less than a VGPR, or we were a little uncertain if you were in a solid remission, I might be inclined to continue, but at a reduced frequency. So we look at the status of the myeloma and the extent of the bone disease to make that decision. But if you're doing extremely well, I would be inclined to stop, certainly in a CR.
Well, Dr. Anderson and I were on a committee to establish the guidelines for ASCO as far as bisphosphonates were concerned. And we made the recommendation that at 2 years, if the patient's myeloma is under control, that the physician should, quote, seriously consider stopping the bisphosphonate. There is absolutely no evidence on giving bisphosphonate at 2-month or 3-month or 6-month intervals. So I think it's more of an emotional thing between the physician and the patient, what they feel more comfortable with in doing.
In terms of stopping or reduced frequency.
Yeah, stopping or reducing the frequency.
Yeah. Sagar, what do you do normally? Is it?
We tend to, at 2 years or 1 year post-transplant,
Sure,
usually,
exactly.
is when we go to every 3 months, and we sit and have a discussion. I think standard risks that are in CR, it's hard to push, but certainly for the others, we go to every 3 months with no data.
Yeah. Okay, well, thank you for your attention, and thanks to the panel.